Without further ado, I will now hand you over to Anna-Therese. Thank you.
Good morning. My name is Anna-Therese, and I'm the head of research and evidence for the HSE and responsible for leading the National Research and Development Office. Today, I'm joined here by my colleague Mairead Murray, who is also a senior member of my team, and we're going to talk to you about our vision for the implementation of the HSE research governance, management, and support functions. So we'll refer to these as RGMS functions for short. You will remember that on the 9th of September, we launched the HSE National Framework for the Governance, Management and Support of Health Research. So this is a key foundational piece of work that articulates the principles for the governance and management of health research in the HSE. It also articulates the roles and responsibilities of the principal actors in the process of research governance and management, the structures needed to put it into practice, and the processes to support staff. So today we're going to be talking about these last two bullet points. So the implementation of this framework, in order to be fully implemented, there is a number of national projects that need to take place. One of those projects is the reform of the HSE Research Ethics Committee. And 2 weeks ago, we had also an information webinar to explain the roadmap to reform the HSE Research Ethics Committees, and the recording is also available in our website if you want to, you didn't have a chance to attend that event and you want to know what this is all about. The second national project that needs to take place is the development of a cohesive RGMS functions at local level. And this is the subject of this presentation today. And also in parallel with that is the rollout of a national electronic research management system. So in order to understand what RGMS means, I'd like to refer to it as two halves of the same apple. So the RGMS function and the Research Ethics Committee work in parallel to ensure that the research activity hosted, enabled, and conducted by our public health services is ethically sound, is safe, and it is done in compliance with the legal and regulatory obligations. So RGMS is not a name that means a single thing. So RGMS refers to a group of functions. And our vision is that all of these functions will be coordinated by a central research and development office. So the role of the research office is to receive applications, is to risk assess those applications in order to ensure that the level of governance is proportionate to the risk of the study, and also to linking with these other auxiliary functions, like if required, the data protection officer, legal and contract functions, indemnity insurance, finance, and HR. And ideally through the rollout of an electronic research management system to coordinate the interactions with the research ethics committees and the host sites. So all of these, I suppose, interventions are currently taking place, but they're not necessarily coordinated or aligned. So if you look at how the RGMS function fits into the overall governance cycle articulated in the research governance framework, you will see that the RGMS function and the REC work in parallel. The principal investigator will log the research projects through the electronic research management system. The project will be received by the research office, which will coordinate with the auxiliary functions, as I said before, and with the research ethics committee. And once the due diligence has been done for a study, the host site will be able to provide an authorization. The RGMS function also has a role in the oversight of the study once the study has started, so throughout the lifetime of the study, because some of these studies could go on for many years. So that is the vision. And now I'm going to hand you over to Mairead to talk to you about how things actually are at the moment and how this vision may address the current problems, I suppose. Maurice, over to you.
So I'm going to talk through two examples. One is about hospital-based research, and it's about to try and highlight the complexities of the current situation for conducting research in Ireland. So the first example is hospital-based research, and the second one then will be community-based research. So we're highlighting a university-sponsored interventional non-regulated clinical study involving 3 hospitals. One of them is a HSE and the other 2 are Section 38 hospitals. So it's fantastic. You've had a research idea. Congratulations. You've got your funding. You've got your consent documents and your protocol in place. And now you can start your research project. So what are the steps that you need to get a research project started at the moment? Well, there are a number of steps. And the first one is the study data protection. And for this, it's, as we said, it's a university-sponsored study. So the first step is that you need to complete a DPIA for the study data in consultation with your sponsor or university DPO using their DPIA template. The next step is but the issue here as well is that even though it's a university that is sponsoring it, you have to remember that you're conducting the study as a HSE clinician. The next step is ethics. And because of the complexities of the system at the moment, for each individual site, you'll have to apply to their relevant ethics committees. So you have your protocol, you have your consent documents, you have your indemnity cert from your sponsor, you've completed your DPIA, and you fill out the rec form. And it is a standard rec form, acceptable across all ethics committees. But what happens if during the review, one of the ethics committees has an issue with the consent? It may be that they have their preferred wording that they would like you to use. And another site might have an issue with the protocol. For example, it may not be standard of care at their hospital or their site, so they've asked you to implement a change. And of course, once you've implemented a change in the protocol for one site, ideally you should implement it across all sites. And you may consider that a change in the PIL should also be implemented across all the sites. So you get everything lined up, you version control, date, and resubmit all your forms, and you have your ethics approval. The next step is to get hospital sign-off, legal. So again, you have multiple parties for the legal agreements. For each site, you will have the relevant entity, be it the HSE or the Section 38, the university, and you'll also have to reference the funding terms and conditions. So for the site to review and to approve for sign-off of your agreements, you'll have to submit a number of documents again, a DPIA, your indemnity cert, your rec approval, and there also will have to be a discussion on funding or resourcing or the financing of the study for the site. One of the issues here is the fact that for this DPIA, what the hospital is looking for is a DPIA in relation to the patient data or the site DPIA. So the DPIA completed as part of your ethics application may not be relevant to the hospital's review of the legal agreements. So what this means is that you now have to go to your site data protection. And due to the complexities of the system and the legal requirements that each of these data controllers or entities work under, for each site there will be an individual DPO. They will have their own template DPIA that needs to be completed. And again, they will have to look at the agreements, the protocols, the consent documents, and they may even ask to see your rec approval. So what happens if at this stage, one of the DPO reviews of your DPIA highlights an issue with your consent document? It could be that the site's preferred wording has not been used, or it could be that they have identified something that was not obvious during previous reviews. Again, these reviews are not standardized and template agreement DPIAs are not in use at the moment. So if it is an issue with a consent document or the protocol, it means that you have to go back to ethics and the approval that you had in place now has to be changed. And it could be that that change that has been suggested needs to be implemented again across all their sites. And remember, you're waiting on your legal agreement for this DPIA to be in place. And to do that, you have to go back to ethics and resubmit an amendment. So you do this, you get your ethics, you get your DPIA, your legal is done. And now the last step is actually legal will want to see that the study comes under the clinical indemnity scheme. So they will go to Aon or the State Claims Agency and they will ask them for confirmation that the study meets the requirements to be included under the clinical indemnity scheme. Now, we talked about indemnity already, but that was the indemnity provided by the sponsor of the study, and it doesn't cover the hospital indemnity or the malpractice or clinical negligence indemnity required. And the hospital will want to ensure that this is in place. And for that, they have to get confirmation that the study comes under the clinical indemnity scheme. So that's the final step before you can go back to legal and say everything is in place to sign the agreements. So now at this stage, your parties can all sign their legal agreements, and actually, congratulations, you can start your research study. So as you can see, it's a complex system, and that's currently what is in place. Some studies will be easier, and some studies will have even more additional complexities. So what happens if we look at what's happening in community-based research at the moment? So a national research study commissioned by the HSE, conducted by an academic institution and involving a survey of staff users of community-based HSE care services. So the HSE has commissioned you to do a research project that will contribute to inform future service development strategies. This is an important piece of research for the HSE. Congratulations, you've succeeded in your tender bid and the HSE is sponsoring your project. You've designed the protocol in collaboration with your HSE partners, the consent documents and the resources and the study for your site have been identified. So again, the first step is data protection. And this time you have a university DPO review and a HSE DPO review. And again, we have to use different templates dependent on what entity is doing the review. You need to go for REC approval. University REC approval is okay. But for the HSE, we have the additional complexity that currently 4 of our community healthcare organization RECs are not operational. So your options in this case are that the study cannot proceed, or you proceed once the sites without a REC are excluded from your study, which has implications, of course, on your sample size and the fact that the study is no longer a national one. Or you find alternative arrangements that are not aligned with the RGMS framework. In other words, a workaround that enables the study to continue. So that's the complexities of the current situation, highlighted using 2 examples. So what are our next steps to try and resolve this and make it easier to conduct research in Ireland? Well, one is the REC reform and the other is the RGMS development. And these are building on a body of work that has already been completed by the National Office for Research and Development. The roadmap for the reform of the HSE Research Ethics Committees and the HSE National Code of Governance and Management for HSE Reference Research Ethics Committees has already been completed and is in a consultative process. The roadmap for the establishment of the RGMS functions and the code of practice for the implementation of the RGMS function are both in progress. So what will this code of practice for the RGMS function look like, and what will it contain? It will define the scope of the RGMS function and the expertise required to implement it. It will define the function of the Research and Development Office. It will outline approval workflows, including liaising with HSE RECs, and it will contain standard operating procedures and relevant guidance on study risk assessment, sponsorship, or responsible legal entities' roles and responsibility, allocation of same. It will outline PPI involvement indemnity and insurance requirements, data protection, contracts and legal requirements, financial management of research, human resources and recruitment considerations, and site approval. As part of the implementation of the RGMS function is the rollout of a national electronic research management system, or ERMS. And this is one of the key requirements for the RGMS function to function. What is ERMS? It's a single portal for research governance management support function and research ethics committees applications. That's HSE research ethics committees and not NREC. It's a national system. It will have national, regional, and local level implementation, and it will have one application and one document set. It will, of necessity, be complex, and behind the scenes, it will be a series of moving parts with one application divided into sections and avoiding duplication where possible. It will take all the different forms that are required as part of a research approval, and instead of asking you to upload them individually as required or send them on to the relevant parties, it will facilitate this internally. What you will see is one simple portal with a login, and behind the scenes, the complexities will be dealt with. This won't be easy, but we are working with our partners to make it happen. The vision is one online application to include the application to HSE Recs for acute, community, national and corporate services, one upload of additional documentation, and a national standardized approach by using agreed templates. And we are working with the Health Research Data Protection Network and the HSE DPO to make this happen. There will be nationally agreed and standardized approval workflows. Proposals will be risk assessed and low risk proposals will be expedited. The State Claims Agency or Aon indemnity review will happen only once, even if multiple HSE and Section 38 organisations are involved. The additional elements will be that there will be HSE governance protocols, and these will be, where possible, coordinated with university protocols. We will collect research activity data, research that is ongoing in the HSE at the moment, and this will help us to assess impact and devise strategy. And we will ensure that research will be focused on Irish healthcare users and healthcare system. So the vision, as we said, or as I said, one application form, one document set, everything under one umbrella, including governance and PPI, and one approval. So I'm going to hand you back to Anna now, who's going to talk about the organizational structures required.
Thank you, Marie. The RGMS functions need to be set up within a national context in order to achieve that national cohesiveness. But by nature of the fact that research in hospitals is different to research in community services, and that is different to that in national and corporate divisions, different arrangements need to be put in place. So the first thing that we need to set up is the HSE National RGMS Oversight Committee. We're in the process of doing that, and this will be a committee of senior membership that will include a variety of representations, including academic representation, HSE, senior management, community, hospitals, and also patient representatives and others. And the role of this oversight committee is twofold. On the one hand, they will be responsible for ensuring that the implementation of the HSE research governance framework results in a cohesive national environment, as opposed to an ad hoc implementation in each site that will lead to further, I suppose, inefficiencies. The The National HSE Research and Development Office is already in place, and that office will report and work together with the National RGMS Committee. So for the hospitals, what is required is that at the level of the hospital group, a research governance board needs to be set up. So this research governance board already exists in a number of hospital groups, and it has representation from the hospital group senior management team, but it also has representation in general from the university management team, because the hospital groups, they have one or more academic partners, and it is reasonable that both representations are part of this committee. In fact, a lot of the research that takes place within the HSE, it does so in collaboration with the universities. Then another important role that exists in some hospital groups, but by and large not in others, is the research lead. So in some hospital groups, this is referred to as the hospital group director of clinical research. So this is the person responsible for ensuring that the governance and management is cohesive throughout all the hospitals within the hospital group, and is also responsible for leading the hospital group research and development office. So this research and development office, as I said before, has an important coordinating role, and it will link up with all the hospitals within the group. So how does this linkage take place? It will depend on the different structures that may be in place at local level. And this will be influenced by a variety of things. For example, the size of the hospital, for example, the level of activity and of research activity that is taking place within the hospital. And of course, the levels of resources at local level, etc. So these structures then could be at local level a hospital research committee. It could be a small research and development office at hospital level, or it could be a single individual that takes responsibility for the research in that organization. And that is how the hospitals by themselves linking with the hospital group research office and the hospital group research lead. And of course, we have also the clinical research facilities, which are in general academic research facilities, but there will be a dotted line to the research governance structure at the level of the hospital group. So if we explore in a little bit more detail how will the actual RGMS function exist within this national structure, you will have the hospital group research and development office providing support to all of the hospitals in the group. They will receive the applications, do the risk assessment, manage the electronic research management system, and also coordinate with the research ethics committee, with the host site, and with the auxiliary functions, such as the data protection officer, legal and contracts, etc., when required. So how does this coordination take place? It will very much depend on the type of hospital within the group. So by virtue of the fact that the HSE hospitals and the Section 38 hospitals are different legal entities, that has an impact on the workflow, so that they will need to be designed for each hospital group and for each hospital. And that is what the electronic research management system aims to address, all of those complexities, while at the same time maintaining national standards. So what is happening then? What would be the ideal scenario for the community services? So in the community, there is less research activity than in the hospitals, and we are still exploring what is the best arrangement for community services. So we need to, the plan for 2022 is that we're going to scope the need, and we may pilot through the provision of RGMS function through the National R&D Office. We may pilot this in a relatively small community area in order to really learn how things work in the community and what is the best design. Taking into account that we are in the process of moving with this launch care towards regional health areas. So whatever structures are put in place need to be capable of morphing into a research governance structure that will be then aligned to this launch care RHAs. So then we have research taking place in national and corporate divisions. And people wonder, is there research going on in national and corporate divisions? And the answers to that is yes. In fact, there is a lot of commissioning of research at national level to inform service developments, etc. So the idea is that the National Research and Development Office will provide that RGMS function to the corporate divisions and national services. And again, either with resources within the office or by linking in with auxiliary functions, we will be able to support research projects with the requirements for contracts or linking in with the data protection officer, etc. So as you can see, this is a complex project. It's not going to be achieved in one day. And here you have the timeline that we propose as part of the HSE action plan for health research. We've moved past establishment phase. We're now in the development phase where the research governance framework has been launched, and we're in the process of figuring out how to implement this. As you well know, we've lived through very difficult times. We had a pandemic, we had a cyber attack, and that has had a very negative impact on our the ability to do our work, engaging with the system. It's a very challenging environment, but we are hopeful that we'll be able to pick up the pace again and make up lost time to align with the original timelines that we had in mind. So obviously all of this work is not being done by ourselves in my team alone. We are working with a broad a group which we call the RGMS Implementation Working Group, which has a broad representation and is led and supported by my office, but that also works in the work that has been done by other people. For example, the work that was done by the corporate enabling of clinical research is very important to us because it allows us not to reinvent the wheel, but really understand how this may be the preferred course of action for the academic sector, how to build on that. There is also other national groups, and Murray mentioned the Health Research Data Protection Network and others there that are also working in trying to achieve a national approach as to how we do things with regards to research governance. And we're hoping to capitalize on work already done and linking with groups already in existence to make sure that by working together, we achieve this vision. So just to wrap it up, we are going to have a number of questions and answers, and we would just want to give you a 5-minute break, and these 5 minutes would allow us to gather all of your questions and get ourselves ready to answer the question over the next half hour or so. So thank you for your attention, and please come back in 5 minutes. Hello, everybody, and thank you. I hope you had a chance to get a cup of coffee and that you all came back after our presentation. I'd like to introduce also Declan O'Hanlon, who is going to be helping us today to sift through your questions, and hopefully we'll have time to answer them all. So over to you, Declan.
Very good. So we've had a lot of questions coming through the Q&A function during the first session and during the break there. And as Anna said, we'll try and work through as many as we can. If we don't get to all of your questions, and if you haven't included your contact details, you can resend it to researchanddevelopment@hse.ie, and we'll try and get back in touch. So where will we start? Maybe first question then to Mairead. There's a question here that says, what are the timelines for the implementation of the ERMS system?
So the ERM system is hopefully going for tender early next year. And then once the tender process has been completed, we envisage that it will be rolled out on a phased basis, because obviously there'll be resources needed on the ground to actually implement it and to support it. So as research and development offices come on stream, the ERMS will be rolled out on a phased basis. So hopefully over the next while, it is by necessity a complex system, not just in the specification of the system, but also in the work processes and practices that will stand behind it.
There's a related question here then about Section 38s in terms of their conclusion and inclusion, and it says, what is the forecast timeline for Section 38s on the ERMS?
We currently don't have, sorry, I presume that was to me as well. We currently don't have a timeline on the rollout of the ERMS to the Section 38s. It will depend on what resources are available to implement it, and also how integrated the processes will be. But we do envisage that it will be rolled out to Section 38s, but the exact timeline on it, we don't have set in stone at the moment.
Okay, maybe one for Anna then. I think this is with reference to the timeline slide you might have had up, and it says, so this won't be up and running for 7 years?
No, the timelines we had there were the timelines for the HSE action plan for health research. It's a 10-year plan, but they are not the timelines for the implementation of the research governance, management and support function. So we envisage that the process has already started. So there are some hospital groups that have already set up the research office at the level of the hospital group, like the Ciolta hospital group, for example, and others are already actively moving in that direction. So I envisage it's going to take possibly 2 years. Has started already. Hopefully next year some more resources will come available, and maybe by 2023 or early 2024 we may have a decent capacity to roll this out.
We might stick with you, Anna, there. There's another question just on resources, and it says, will extra resources be provided to researchers on the ground to support them in transferring to this new process? Centralization is great and we welcome streamlining the complex process, but any change takes time and resources.
Yeah, that's a fair comment. I suppose at the moment we are focusing in getting the resources to setting this up, and then in due course, the idea is that the research support office will be able to support the researchers in doing things the right way. But of course, that depends on the capacity to resource these offices. But the role of the research office is to support the researchers in doing all of this, getting through all of this paperwork and all the bureaucracy, I suppose.
There's a related question there on supports that says, can Section 38 bodies expect support from the HSE National R&D Office, or should they expect to have to resource this themselves, at least for the next few years?
Well, the way we are, as I said, the way we are trying to structure this for the hospitals, say, so Section 38, let's assume you're talking about hospitals, although there are other Section 38 organizations that are not, but just for, I suppose, to make it easy for me to answer, imagine you're talking at Section 38 hospitals. If the hospital group is located, so the research office is located at the level of the hospital group. A lot of the resources can be in the hospital group research office, but by virtue of the fact that the Section 38 will be independent legal entities, other resources such as the DPO and maybe legal and contracts, for example, that will be up to the Section 38. So initially, our focus is on obtaining resources to setting up the hospital group resources, and at local level, initially the hospitals, the Section 38 themselves will have to find their own resources. But as I said, I think that there is a concerted effort needed here from ourselves in trying to get resources from the top down, but also from the bottom up. There is to be some willingness, I suppose, to engage with this process and make resources available.
Maybe, Mairead, we'll take one related to the university interaction. It says here, will the universities be aligned to this new system, or will PIs have to submit a separate DPIA rec submission to the universities for every project?
So we have university partners sitting on our RTMS implementation working group, and we are building on the work of the corporate enabling of clinical research working groups, who were both drawn from university and other stakeholders in the Irish health research scene. So we are trying to align with university protocols and work with them where possible. But items like DPIA, I mean, it's a legal obligation on the data controller and the DPO of the data controller to review DPIAs. So under legislation, if a university requires a DPIA review of a DPIA, then that will still have to happen. We can't change the legislation that's already in place, but what we can try and do is put in place standardized templates, research DPIA screeners and research specific DPIAs that are accepted as nationally as possible, or by as many groups. And we are working with groups to do that, like the Health Research DPO Network and with the HSE DPO.
Maybe we've answered this one then with that, Mairead, but it says, what can the HSE do in the short term to provide a roadmap for a harmonised approach to DPIAs for clinical trials? Very different views coming from DPOs in different hospitals.
Yes, there is, and this reflects the fact that for all the Section 38s, they are their own legal entity, and therefore they each act as a data controller for the patient data that may be accessed as part of health research. And it is a legal obligation that their DPO reviews DPIAs. So they have to take on, like, we have to work within the legislation framework that is there, as I mentioned already. So while we can look to devising or to drafting a nationally agreed strategy for how this will be done, we have to do it within the requirements of the legislation that is in place.
Anna, maybe how about this one? How will the work of the HSE staff doing research as part of their own postgraduate program in a university, how will this work for them? A HSE staff member doing a dissertation as part of an MBA, for example.
Okay, so the HSE research governance framework only applies to health research that involves health service users, health service data, health service patients' tissue samples, for example. So if you're doing an MBA and your research does not involve any of those things, or you're not engaging with the health services, just because you are a HSE member of staff doesn't mean that the governance framework applied to your project. So if you were engaged in a university degree or master's or whatever, and it did involve patients or samples or data or facilities within the HSE, then yes, it would come under the remit of the framework, and then you will have to abide to both, the university protocols and the HSE protocols. But the idea is is that we would work in as much as possible with the universities to trying to streamline protocols. Obviously, universities already have some protocols, and we are just coming on the stream and trying to align ours. So we'll take into consideration the protocols that are already there and see if we can, make it as streamlined as possible.
Okay, and if you'd like to keep going there, there's a question here saying that the Royal College of Physicians has an ethics committee, covers community research for members. Will this be brought into the system also?
Yeah, I guess that's a question that we may have answered at the previous seminar about the roadmap for the research ethics, the HSE reform for the HSE research ethics committees. So the vision is that we will have 6 regional HSE reference regs that will cover all of the HSE areas, but that doesn't mean that the other committees that are already there will, be impacted in any way. So we will like to work with committees, with existing committees, so that they can be included as part of our workflows, for example. So to minimize, the idea is to minimize the amount of time, the amount of effort, the amount of bureaucracy it takes to get research up and running, so that there be more research, and that we can create a culture of research within the HSE, and that means working with all our partners.
Maybe a related question to your comment there then, Anna. I'm a frontline researcher in community services. How will you increase the research awareness and encourage colleagues to consider starting a research project if they're not connected to a university?
Yeah, I guess it's a very valid point, but the objective of the HSE Action Plan for Health Research is to develop a culture of research within our health service. So a lot of research in the acute sector, for example, takes place by individuals that did not necessarily have a university affiliation. So the same could take place in the community, but the amount of research that takes place in community services, I suppose, is a lot less than in the acute sector. So I think by building that culture of valuing research, of applying research to improve the service that we deliver, that will all contribute to enthuse people and to engage their interest in the future.
Okay, Maureen, we have a couple of questions here with regards to approval timelines that we might work through, some of which might be similar, but let's kick off. This one is, how will the new process affect overall time for approval of a study compared to current process?
Well, we hope that the RGMS function, once it is fully implemented and the ERMS is sitting behind it, that it will improve approval timelines. Now, we only have anecdotal data on how long it takes studies to be approved to go through the whole system at the moment. So one of the changes will be that once the system is implemented, we will be able to collect study metrics on timelines, on what research is happening within the health service. And this will help us then to put in place approval timelines, but that's a step down the road. First of all, we have to get the system up and running, but we hope that the system, once it's up and running, or we're working towards a system that will improve timelines. It's not just putting the system in place, but having standardized processes behind it, having templates agreed across the system where possible. So it's a series of steps, but all working towards improving timelines.
Okay, 2 other related ones here, and maybe we've covered it, but let me work through them. We're very relieved that this consolidation of an enormous amount of paperwork and possible roadblocks to research is being undertaken. How long would you envisage the process taking for future compared to the long waiting times that are in place to date? And then a related question here noting, will there be timelines for RGMS review? If so, what will these be? There needs to be set expectations and escalation pathways if timelines are not met, which could hold up a sponsor in proceeding with the trial.
Okay, so there are aligned questions, so I'll take them both together. So as I said earlier, we don't have metrics on current timelines. We have anecdotal information and feedback from sponsors, from researchers, from hospitals, and my own personal experience about how long the process can or cannot take. So first step, before we can say this is how long it will take and put a deadline in place or timelines in place, is to actually collect the data on how long it's taking, implement changes, roll it out, test it and check it. And only when the system is stable can we put approval timelines and escalation in place. We know and we acknowledge that it is needed, but it would be premature of us at this stage to put defined timelines in place when we actually don't even know at the moment how long it actually takes on a national scale and across all studies for approvals.
Okay, some further questions just on DPIAs. Anna, no other EU member states have such complex DPIA requirements. Just a comment, it is really holding up trials, and a streamlined template or harmonized review process would be most welcome ASAP.
Yeah, but that's we appreciate that, and I suppose in Ireland we have the health research regulations, which is unique to Ireland, and we have to work within our legal framework. And indeed, that's what we're hoping to do. So the work of the Health Research Data Protection Network in this regard is hugely important. We have also recently have reached an agreement, I suppose, with the HSE DPOs with regards to research, and we have going to develop a work program so that all the research side of things is brought to the attention of the DPO office, and we can work together ourselves, perhaps with the other DPOs within the health service and also with the Health Research Data Protection Network in resolving this. And reaching that agreement is difficult though to reach that agreement. We also need to engage with the DPC so that we get, I suppose, the blessing for the material that is being developed. So it's not an easy process, but it's certainly central, because we appreciate that the enactment of the health research regulations brought about additional complexities that they're not to be underestimated.
Another question here, Anna, about industry and commercial global trials. It says, it would be helpful if you could explain how the new structural processes will impact on industry and commercial global trials. The focus is often just on non-commercial academic trials. Thanks.
Well, I suppose the commercial trials tend to be regulated clinical trials, and this will mean that the process of research ethics approval and regulatory approval will take place through the NREC and the HPRA. But all regulated or non-regulated will have to be registered through the system as well, and that will trigger the generation of the site DPIA, for example. So at the moment, the applications to the NREC may be going with the sponsor DPIA, but by including those projects within this pathway of approval, that means that things may happen in parallel rather than sequentially. So I think you could improve the timelines overall.
A question here about ethics committees. And it is envisaged that the ethics committees will have a balance between qualitative and quantitative research experience?
Yes, so the HSE reference recs will all be working to the same code of practice, and the code of practice articulates the membership. So it's a balanced membership, and the idea is that the members will have sufficient breadth of experience that together they can address quantitative and qualitative research.
Okay, a budget-related question here for whoever would like to take it. An annual budget for the R&D office in the UK hospital university partnership, no bigger than similar in Ireland, had a budget a few years ago of 1.5 million sterling. For a national office in Ireland, the cost is likely to be a large multiple of this. Do you think that this will ever happen?
I think we need to clarify what the role of the national office in the overall context. So I'm not proposing that my responsibilities they are in the national office, that we are going to take over everything. So we are providing, I suppose, a momentum and driving initiatives, but the support will happen at local level. So the research offices for the hospital groups will happen at local level, and with time, hopefully these offices will become the regional health areas research offices, and we at national level will be supporting the national divisions and corporate divisions. And so what I said before about my office supporting the community services, the idea is to do that temporarily to understand what the requirements are. So that doesn't mean that my office centrally will support all the community services. It might be that we will, and then we will need more resources, but initially it's just a pilot. And you know, so we can't, if my office was to provide this support to the whole country, I will need a huge amount of resources, as you will say, 1.5 million probably won't even scratch the surface. So it needs to be, that's why it needs to be distributed, and it needs to be a joint approach between us, seeking funding to fund from top down, but also from the ground up, see if there is any resources locally that can be, you know, pushed towards this effort.
We might have time for a last one or two. There's another question about resources and another one about the REC. This one about resources says, working in a section 38, do we wait for the RGMS office in the group to be set up before setting up a local RGMS office here? Will any funding resources be made available to set up a local RGMS office? No extra resources provided to implement GDPR or the health research regulations. Existing departments had to absorb extra workload created, cannot absorb more work without a budget or permission to hire.
Yeah, no, I appreciate that. The requirements of the hospital at local level depends, as I said, of many factors. So if it's a hospital, it could be a Section 38 hospital that may want to have their own local research office and provide that liaison with their own internal DPO, their own internal legal and contracts, etc. And that's fine. And that in fact exists in some hospitals. And then that will, the hospital research office will be the one linking in with the hospital group. But you still need the hospital group. They're providing a service to all the HSE hospitals. Instead of a hospital research office, you could have something else. You could have a research committee. You could have, depending on the size of the hospital, on the level of research activity within the hospital, you could have a research coordinator. And so again, that depends on how is this going to be funded. As I said, we are focusing at the moment on trying to get the resources for, you know, the macro level. And once we succeed in that, then we will look at the next step below, you know. But in the interim, if there is a demand, I think there needs to be, the research needs to be brought to the awareness of senior management, and senior management needs to understand the value of research to the organization. So this is, we all have a role to play in this equation, I think.
Last question then, we might have time for, is about REC composition. Maybe this was part of the last webinar, but will the RECs be required to have a statistician and a study design or research methods expert involved to review the appropriateness of ethics of study design, sample size, included populations, comparators, etc.?
Well, that is the dream scenario, of course. If we could have a statistician in every REC, we certainly will have one. It is not it's not an essential requirement. We can have a REC without it, but certainly it would be our preferred option to have that expertise. It is hard to have that kind of expertise in every REC.
I think we got through all of the questions that were submitted there, and I think we're out of time. So I'll pass back to Anna. Thank you. Okay, well, thank you very much. I'd like to really thank you for staying with us for the whole hour. And as Declan said, if you have any further questions that you didn't get a chance to ask now and you want to ask them through email, feel free to just send us an email and we'll do our best to answer you.
And just to say that we hope to keep people informed through this mechanism of webinars works quite well. So over the next year, we may have other information seminars just to tell people how we're getting on with the rollout of the ARMS, for example, and other initiatives that we are working on. For example, the HSE consent for research policy, which is also in the final stages of development, and other work that we're doing. So we'll keep you informed. Thank you very much.